the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Hello, listeners. Sam Dyer back today to tell you about this week's podcast. Today, I wanted to go backwards in time somewhat. At our 2018 Charlotte meeting, we hosted Dr. Jake Drew. Dr. Drew is with the Beth Israel Deaconess Medical Center, Department of Orthopedic Surgery, and he also instructs students on total joint arthroplasty at the Harvard Medical School. He gave a presentation on the difficult primary hip planning and execution, and that's going to be the subject of our podcast for this week and for next week. The questions that he answers include what makes a primary hip difficult. He gave several examples of this, including obese patients, post-traumatic degenerative joint disease, post-radiation therapy treatments, revision arthroplasty approach considerations. Thanks for listening, and I hope to see you soon at one of our conferences.
So what makes a primary total hip replacement difficult? Again, when I think of a difficult hip, first thing that comes to mind are these, BMI 40 plus behemoths that just make for a long afternoon. All right, but exposure in general can be challenging, not only with the obese patient, but in the patient who's had prior incisions. You have to get around scar tissue or bear in mind how you're going to get exposure in a hip that's already been operated on for some other reason. Bony anatomy can cause issues via a number of different avenues. So we spoke about this particular patient being of unusually small stature and that posing some challenges. DDH is something that comes up quite often. Perhaps we don't see as many severely dysplastics as we once did, but certainly there are enough mild and moderate DDH hips out there that those are, without question, more difficult than your standard primary osteoarthritic hip. Post-traumatic osteoarthritis definitely carries some concerns, whether it's pre-existing hardware, whether it's too much or too little bone. There's some concerns that you have to address. And many of these patients, via one avenue or another, are going to have some intrinsic risks for instability. So we'll go through the decision-making process and how you make a hip that seems unstable intraoperatively stable. And finally, I want to consider just a couple of concerns with respect to achieving fixation. So this patient that I just mentioned was severely osteopenic. Other patients might have alternative issues, and one that I want to bring attention to is the patient who's had prior radiation. So that's a brief outline of what we'll talk about here. So I don't have any great answers for the obese patient. Tell them to lose weight, make it easier 6 months, 12 months down the road. Obviously, that's not going to happen all the time, and you're going to be in the operating room with a patient who does not have the ideal body habitus. And so just a couple of points here that I like to make. You heard a talk earlier today discussing direct anterior approach versus a posterior approach, or anterolateral or lateral approach. So for me, I consider myself a direct anterior surgeon. That's probably about 85% of the primary hips that I do. But I have a couple of hard stops when it comes to a direct anterior approach. And one of those is the belly flop sign. And so in the world of shared medical records, when the patient has the ability to read their note immediately after you sign it, this becomes the positive BFS in my note, all right? But if a patient has a big overhanging pannus that's going to flop down right over where you're going to make that anterior approach incision, in my mind, it's not worth the increased risk of infection, not worth the increased risk of wound complications. Those patients get a posterior hip from me. So that's a hard stop. Whether a posterior, anterior, or any other approach, don't ever let your incision length compromise your component position or fixation. So if you're doing a posterior approach and you've got this tiny little incision in this great big patient and you're going to put your acetabular component in 60 degrees inclination as a result, don't do that. Make that incision a couple of inches longer if you need to. Put the parts in the right spot. The patient will thank you for that far more than they'll thank you for an incision that's slightly shorter than it otherwise might have been. So when you're positioning these patients, that's often an unappreciated time sink. So certainly you're going to allot a little more time in the operating room to perform a total hip replacement on an obese patient. What you don't realize is if it takes 5 or 10 minutes to position the typical patient, it's going to take at least double that for the obese patient, and it's a safety risk. So if you don't get them positioned appropriately, all prominence is well padded, all the pelvic position is secured properly, that's a safety risk. So make sure you have extra hands on board so you don't throw out your back trying to position this patient, and make sure everything is tightened down. I have absolutely had occasions where these pelvic positioners pop loose during the middle of the case, and now you're wrestling this big patient while somebody's under the drapes trying to get it tightened up again. So take your time. Positioning is not to be ignored or taken for granted, and make sure you have plenty of people there to help. Deep retractors, most hospitals these days have deep Charnleys or other retractors, long-handled retractors. You're going to need those if your patient is particularly big, and make sure you have the tools that you need to do the job. So incisions about the knee, often this comes up in a revision hip situation, but not uncommonly in a post-traumatic situation if the hips had prior surgery. We worry more about parallel incisions in the knee than we do in the hip. The hip tends to have a larger, more forgiving soft tissue envelope. So generally speaking, parallel incisions are going to be okay in the hip as long as they're about 5 centimeters spaced apart. The concern is if you leave a narrower zone between the incisions, there's risk of devascularizing that skin and having skin necrosis as a consequence. Most of the time around the hip, you can use some variation of the previous incision. Sometimes you might have to extend that, and if you're going to veer off and turn a straight incision into a Y, it's often best if you have that Y limb come off the incision at as close to 90 degrees as you can. Again, that will forgive some of the vascularity issues around that skin and be a little bit safer. So with the difficult primary total hip, you can do any of the 4 traditional total hip approaches. I'm not talking here about the mini approaches, this or that, but probably you can do those as well. Just bear in mind that any approach is going to have some relative advantages or disadvantages versus the other approaches. So generally speaking, as I said, I do anterior and posterior. Those are sort of my 2 tricks. For me, if I think there's any risk of me needing to access the posterior column of the pelvis, that's a reason for me to go to a posterior approach. You can do it from the anterior approach, but it's awfully challenging, and I think any perceived benefit from that anterior approach is lost if you have to go digging around trying to get to the posterior column. So all of the approaches are extensile. It's just some are more extensile than others. And so another consideration for the direct anterior approach, if I know I'm going to be using a stem, such as a diaphyseal modular stem where I'm going to have to get long, straight reamers down the canal, I need a direct shot down the canal. Sometimes that's really difficult to achieve with a direct anterior approach. Again, it can be done, but is it worth the additional exposure, the additional time to get that access that you need, where you can probably do it a heck of a lot easier through an alternative approach? So again, I don't think there are any strict, absolute contraindications to any one approach, but I try to be thoughtful in what a particular case is likely to yield in terms of challenges and do the most appropriate approach for that reason. You know, if you're doing multiple approaches, you ought to be able to get the equivalent result from any of them. There's not a grand enough difference from one approach versus another that, I have to do it this way because the patient's going to do so much better. No, they're pretty close at the end of the day. So do the approach that makes the most sense for that individual patient. So post-traumatic hip. So these are often more challenging than the standard osteoarthritic hips. So this is an example here where this patient clearly has severe degenerative disease and also has a fair amount of pre-existing hardware. So that's a posterior column plate from a prior acetabulum fracture. And so there are some questions to ask yourself when you're preparing for a case like this. What kind of bone stock are you going to have once you get in there? So it looks here like that hardware was intended to not only fix the posterior column, but we have these smaller pieces of metal in there that were probably spring plates holding down the posterior wall. So you don't know if you're going to get in there and have any posterior wall to work with. You don't know if you're going to get in there and have any posterior column to work with. You could get a CT scan, could give you that answer. But if you're going in there without a CT scan, you might want to have a cage available just in case you have more bony deficiency than you might have otherwise been prepared to deal with. Similarly, not so much on this case, but in post-traumatic hips that involve the femoral side, might not be a bad idea to have a diaphyseal fit stem available, just in case it turns out that your proximal bone, the metaphysis, is insufficient to support some of the conventional stems. Post-traumatic deformity can not only yield less bone than you need to achieve a stable hip, it can also result in more bone than you want. So depending on how this fracture healed, some fractures heal with abundant callus, some fractures are going to heal in a non-anatomic alignment, and you might end up with bone in places that you don't want it or need it. And in those situations, if that bone is in the wrong place, it can lead to impingement and instability. So I'll talk a little bit more about that when we get to ways to address instability, but that's often an issue that comes up with a post-traumatic hip. Finally, when it comes to removing hardware, there are some cases where it all has to come out. For example, that DHS screw that we saw in that first case I gave, all that has to come out in order to put in a total hip. In this case here, you don't have to remove all of this hardware. And so my plan going into this case would be to have the screwdrivers available in case I need to remove a screw, to have a metal cutting burr available in case I need to just cut out a piece of that plate so that it doesn't interfere with my acetabular component. But I would not plan on removing that entire plate unless, of course, I was dealing with an infection or something like that. More likely than not, you'll be able to put your components in while retaining this type of hardware. And if a little bit of it is in the way, then just take out the little bit that's in the way. It certainly saves the patient a big exposure, stretching the abductors, risking the gluteal neurovascular bundle. Post-radiation bone. So this is a situation that doesn't come up too frequently, but it comes up enough that you ought to have it on your radar and know how to deal with it when you get into that situation. So this is a 77-year-old guy. Came to me with hip pain. He's had pelvic radiation for bony metastases after prostate cancer. And so that's concerning. And the reason that's concerning, when you have a wide beam, high dose radiation such as that administered for this reason, metastases after cancer, the resulting bone is often dead. And so that pelvic bone, that acetabular bone, is going to have very limited ability to achieve biologic fixation, which is what we're asking the body to do anytime we do cementless implants, right? We put them in nice and tight, and that will work for a while, but unless the body provides bony stability, bony ingrowth, you're not going to have a good long-term result. And so we could get in there and put in a cementless acetabular component, but if that never ingrows, it will ultimately loosen. So in those situations, you have to consider alternative means of fixation, cement. This bone also has a tendency to fracture, and if it fractures, it has a tendency to not heal for the same lack of biology that I mentioned as a concern for the potential to ingrow. And so don't ignore somebody who tells you they've had radiation to the area around the hip after previous cancer or for any other reason. So intraoperative findings for this guy, he had both of those. So we reamed his acetabulum. There's no bleeding bone whatsoever. No bleeding bone. That bone's not alive. It's not going to ingrow. He also had a minimally displaced but not stable fracture in his acetabulum. So if we had gone in there and the only thing I found was a bunch of dead bone without a fracture, I would have cemented his cup. As soon as I also witness a fracture, now I've got to provide him mechanical stability in addition to a means of fixation that does not rely on his biology. So that's why he gets a cage in addition to cement.
Thanks for listening today. Come back next week when we continue the difficult primary hip planning and execution with Dr. Jake Drew. If you want to see some of the images that you hear in this talk, this comes from prior AV recordings that are on our website. There are free resources for PAOS members. We have videos that are no longer valid for Category 1 CME that you can use as a reference. All you have to do is go to the Learning Center. Members can look at these AV recordings for free.